Good afternoon, everyone, and thanks to the HRB for this invitation. I'm delighted to be here, and I'd like to give you my perspective on our research that was funded by this Secondary Data Analysis Award. Grateful for the HRB for funding a number of our studies in the last couple of years. But when I came here first in 2012, the first study I put in was not funded. And the answer was, and I remember clearly, the HRB does not fund infrastructural developments. And I understand that now, but it certainly got me thinking. So what I want to do is not just present the final analysis from a particular study, but I want to take you back before that study ever started and take you on a journey that was peppered with some challenges, a couple of potholes, and a few showers of rain. And in my talk, I'll focus on what I think the challenge or the problem is with regard to health data in Ireland and linkage and sharing. Secondly, I'm going to talk you through our solution, which we had to develop de novo. And finally, I suppose I will mention, and actually you have heard from Sarah, the vision for the future, which is fascinating. It seems to be a lot of work, and I look forward to the timelines that it takes to get that body of work to be done, because it looks like a huge body of work. So the problem is, if I ask you a question, I know you're from different backgrounds here, but this is straightforward, I suppose. Diabetes is very common in Ireland. And if I asked you, or people working in the field, and I know there's a couple of diabetologists, how many patients have type 2 diabetes in Ireland? If I asked you, of these, how many has good blood glucose control? Or how many of these have or will progress to one of the serious outcomes, kidney failure? And what are the effectiveness of current treatments based on Irish data? And I would wager that nobody here in the audience could tell me. And if we go back to the first one, how common is diabetes? This is from a parliamentary question asked in September 21, 2 years ago. And the answer is, well, it's underlined in red. We have to go to Scotland to get our estimates. So in 2023 or 2022, the state of affairs doesn't look too rosy. But, a lot of good things have happened. And we now can remote monitor in real time astronauts in space millions of miles away. We can now operate on individuals with a robot, a Da Vinci robot, 100 miles away. But yet, we don't have any simple answers to simple metrics with regard to chronic disease in our health system. So the question is, why don't we know what we should know? And I think you all know the answers. We are bedeviled with paper-based records, certainly in the hospital system. The electronic record is a fantastic development, which hopefully will come in time, and it has been embraced by many, many groups. All of us here, I know, are behind it. But if we, again, listen to the Oireachtas Health Committee, I think in January of this year, it'll take 5 to 7 years for this system to roll out. And I'd probably add about 2 to 3 years for, just to warm up and get things on the road. So what I'm saying is that we have a lot of work to do. The other issue is we have health data, really good clinical data sets, national data sets, regional data sets, but they're kind of hidden in a silo. and it's hard to access them. Everybody's looking for a way to get rid of those silos. The GPs, the consultants, the allied healthcare professionals, the epidemiologists, the statisticians. But we haven't done that really. And that's why Ireland has lost out over the last 20 years, because we cannot link information to get a longitudinal profile of a patient who enters the health system, gets some care, cross specialties, attends the hospital secondary care system and comes back. We cannot track the journey, and because of that, I think we are poor. We have lost out, and our patients have lost out. So the challenges, and I think Sarah has mentioned some of them, and certainly when I was starting off trying to plot a pathway, we don't have any single entity or organization to facilitate us in doing this kind of work. There was no blueprint to follow in this country. There is no single data warehouse for all available national or regional data sets. There is no unique identifier at this time. There is no data linkage center, and there's lots of silos. So this is the challenge we have in 2023. And when you engage with people over the last 5 years, and you're knocking on the door, some of the time, a lot of times they say, we can't do that. And that is, that certainly kind of affects the morale. And even some of the simple things, where is the data? Who is the data controller? Will you share the data with me? That is always another big challenge. And in Ireland, a context I found it's very hard to get access, even to the national clinical data sets. We can't get it. The people who should get it can't get it. And I think, again, we're missing out on that. So has anything changed? And yes, the COVID pandemic happened. And almost overnight, everybody became a modeler, an epidemiologist. And if you look at Twitter, over the ensuing days to weeks, there was multiple people, from physician to journalist. It was amazing. But the most important thing for Ireland was that they accelerated the development of a national data hub. That has been hugely important. So when I look at this, I say, in a 3-month period, they developed the National Data Hub. They had the legislative framework. It was an accelerated, production. Why can't we do that for chronic disease? Particularly because it accounts for most of the deaths anywhere in the Western world. It's not COVID-19, it's chronic disease. So I think we need to not just, do what is, I suppose, advanced by Europe at a European level, but we have to have an accelerated pathway. That's what I think time is really important here. So in our own program, we wanted to, look at a major chronic disease like chronic kidney disease. Very common, impactful, harmful, and it will become the 5th most common cause of death in about 10 to 15 years. We want to do the simple things. Measure the burden of disease, quantify the impact on outcomes, measure quality of care, and really help our patients and help the health system. That's the basic tenets of it. The solution was really, get into your car and go on a journey. And I suppose along the way, you do tend to build a coalition of the willing. There are great people out there, all you people, and there's fantastic people, just to identify those enablers, those catalysts that can help you along the pathway. And when things don't go right, just write to the minister, send him a letter, write to the Department of Health, write to anyone who you think is an authority. And there's a period of convincing. You've got to convince them that this is good for patients. And so over the past number of years, this is before any research is done. Before any research is done, we have to develop the infrastructure. And maybe if we can do that, then we can do something important. So over the last number of years, we let out on this type of surveillance program with a number of partnerships, and I've highlighted them here. It's important. There's academic partners with groups that have got expertise both in Europe and in the United States. It's hugely important to have those relationships with the state partners, the governmental agencies, the National Renal Office, Health Intelligence, the Central Statistics Office. And also we had to plot a pathway with the governance regulators, the Data Protection Office, the Central Statistics Office, and finally the Health Research Declaration Consent Committee. So these are the type of journeys, both horizontally and vertically, that we had to make to try and move this forward. We wanted to build something at a regional level and hopefully scale it up region by region to national level. So we focused on the Midwest region, you can see here in green, and the Northwest region in, as you can see there. And hopefully if we can do it for those regions, then hopefully we can scale it up from a national perspective. And the overall goal was to link clinical information at a regional level with nationally recognized, strong validated data sets. That includes hospitalization, mortality, with blood tests coming from the laboratories. And the challenge was, as you mentioned, there is no unique identifier. So we developed an algorithm to link individual patient data based on multiple identifiers. And John Ferguson, who's now in Galway, published that about 4 years ago. And there's ongoing iteration of that to identify somebody as being unique and not somebody else. So our linkage algorithm. And then with a number of information governance and data protocols, we were able to extract data from the primary data source, encrypted, transmitted to the Data Coordination Center, decrypted, link it, and then irrevocably anonymize the data. So then we have a final linked data set that we can use for analysis. So eventually we come to, well, we can do some research now. And I'll just present you with 1 or 2 slides that highlight the work we've done just recently. I suppose it's important to say that once you have linked data sets that span the primary and secondary care system, then you can create individual cohorts to ask many, many questions, whether it's quality of care, whether it's the achievement of core indicators, whether it's the impact on hospitalization, whether it's a cost analysis. So the linked data set allows us many, many opportunities. And in this particular one, we linked with hospitalization mortality. So this graph here, I don't have a pointer, I don't know how it works, but it shows the relation between kidney function on the x-axis, and as your kidney function goes from over 90% to less than 30%, you can see there's a big rise in the risk of hospitalizations for both men and women, with men predominating. In other words, those patients with advanced kidney disease have about 4 to 6-fold rise in hospitalization. Huge, high-risk group, those individuals with advanced kidney disease. And similarly, when we look at mortality, there's a huge mortality for these patients. In fact, if you look at the mortality for men is 9-fold greater than those in the general population, and women, it's 18-fold greater. And what is interesting is that with worsening kidney function, women have disproportionately more deaths than men, such that, with advanced kidney disease, women lose that survival advantage. The future direction is, with partnership with the different state agencies, is expansion. And that's what we'd hope that will happen, hopefully, this year with buy-in and support from the HSE and other colleagues. My final slide is the vision for the future. And as Sarah has mentioned, there's fantastic examples of trusted research environments. Scotland, the UK, and Northern Ireland are now advancing it. We really need to get moving on this as a group, as an organization. I mean, I think the lives of our patients and the outcomes of those depend on this. So my vision, our vision really, is to maximally utilize all health and social data, to use that data to produce evidence. We need a data safe haven, and I think you'll hear about that from the next speaker. We need to inform and educate the public that this is for them. This is why we use their information. And I think rather than just presenting data and publishing it, that data has to be fed in the results in real time back into the health system, not 5 years. We want implementation now. So that's the importance of a direct feedback system. And I think if we can do this, then we have the potential to transform our health system. Like any other effort, this was a team sport, and many, many people have been involved in that, from Limerick and beyond, with partners across Europe and the US. The University of Michigan, the CDC, have been hugely important. They have done it for years. We are just learning from them. And of course, very grateful to the HRB for their support. So thank you.